The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have one of our vascular surgeons, Dr. Mohamed Zayed, here to review the management of cerebrovascular disease. Dr. Zayed is a professor of surgery, radiology, molecular and cell biology, and biomedical engineering at WashU University in St. Louis. He is the director of vascular surgery research and the C. Weiss Center.
Thanks, Ryan, for having me. I'm excited to be part of this show.
My name is Ryan Wahidi. I am a second-year integrated vascular surgery resident, and I'll be your host for this episode. Our topic today is cerebrovascular disease. We will be focusing on carotid artery stenosis in particular. 87% of strokes are ischemic strokes with potentially devastating neurological consequences for patients. Of these ischemic strokes, approximately 20% can be attributed to embolization from an extracranial carotid artery. Let's jump into a clinical scenario to guide our discussion. A 73-year-old male is referred to you with concern for carotid artery stenosis. Dr. Zayed, what are you looking for in history and physical to guide you in evaluating this patient?
Oh, thanks, Ryan. In a patient like this who's 73 years old, you'd want to anticipate what are the modifiable and unmodifiable risk factors associated with cardiovascular disease more broadly, and then also related to the carotid artery stenosis. So what we're looking at is the patient's history of smoking, diabetes, hyperlipidemia, hypertension, and other risk factors that could enhance the patient's risk of cardiovascular disease. Once these are delineated and we have a better understanding of what the patient's morbidities are, we can then assess what is the patient's symptomatic versus asymptomatic status, meaning is the patient having symptoms related to the carotid artery stenosis. And the things that we're really interested in looking at is the patient having any symptoms consistent with transient ischemic attack, or TIA. And that's basically if a patient is having ischemic neurological deficits that are returning back to baseline within 24 hours of occurrence. And we want to know if the patient is having these symptoms with any kind of cadence or frequency. Are they having it every day? Are they having it multiple times a day? And over how long? Has it been several months? Has it been over the past just 1 month? Or has it been going on for more than 3 to 6 months? Additionally, you'd want to ask the patient about a history of amaurosis fugax. That's a subcategory of TIAs that leads to transient vision loss, which is associated with basically emboli that are originating from the carotid artery and transiently occluding the ophthalmic artery on the ipsilateral side. Patient usually describes this as changes in vision that are unilateral, sometimes described as a curtain or a blinder coming over the vision of one eye, or complete blindness or in one of the visual fields. Additionally, you'd want to ask the patient if they have a history of a stroke, either on both the ipsilateral or contralateral side, and how they've recovered from that stroke. Did they have a complete recovery or partial recovery or permanent disability as a result of that stroke? Really, what we want to do at that point is, once you've determined if the patient is asymptomatic versus symptomatic, is then determine what are the key options for this patient. Clinical trials have been conducted in the past to assess patients with asymptomatic versus symptomatic disease, and most notably are the NASCET and the ACAS trials. The NASCET stands for the North American Symptomatic Carotid Endarterectomy Trial, and the ACAS trial stands for the Asymptomatic Carotid Atherosclerosis Study. And both of these studies evaluated patients that had carotid artery stenosis outcomes in terms of either getting medical therapy versus surgical management. The operative management for asymptomatic patients was whether they had more than 70% stenosis and at least 3 to 5 years of life expectancy. And the operative management for symptomatic patients was whether or not a patient had more than 50% stenosis. And in the setting of a recent stroke with either carotid revascularization or medical therapy, what we found is that these studies showed that there was a benefit to surgical intervention. Now, one thing to note is both the NASA and the ACAS trial had medical management arms that did not include statin therapy. Nowadays, optimal medical therapy consists of antiplatelet therapy, for example, aspirin 81 milligrams daily, antihypertensives, although not a single particular agent has been found to be superior than others in terms of outcomes. Glucose management in terms of management of type 2 diabetes with a target hemoglobin A1C of less than 7, as well as complete smoking sedation. In addition to that, statin therapy is a centerpiece of the medical management of patients with carotid artery stenosis.
Thanks, Dr. Zayed. You mentioned in your determination of whether or not to pursue medical or surgical management for these patients, the importance of the percent stenosis of the lesion of interest. What is your first-line imaging modality for assessing the percent stenosis of a carotid lesion?
So to manage patients with carotid artery stenosis, there's carotid artery duplex, which is a ultrasound test that evaluates both the B mode images of the carotid artery as well as the arterial waveforms of the velocities within a carotid artery. These types of combination studies allow you to be able to not only see the vessel contour and the contents within the vessel, for example, calcified plaque or mobile plaque or even mobile thrombus within a vessel. But in addition to that, it allows you to have an indirect measure of degree of stenosis. The higher the velocity, the higher the degree of stenosis. And there are several criteria to evaluate the extent and severity of stenosis within a carotid artery. But generally speaking, a peak systolic velocity greater than 230 centimeters per second is suggestive of a 70% plus stenosis. And an end diastolic velocity of greater than 100 centimeters per second is specific for 80% plus stenosis. And usually sometimes we will, in adjunct, look at the ratio of the velocity, the peak systolic velocity in ICA, the internal carotid artery, to the CCA, or the common carotid artery. So ICA to CCA ratio of greater than 4. Again, suggestive of a more than 70% stenosis.
Oftentimes, after we know we're going to pursue surgical intervention for these patients based on the carotid duplex, we do end up obtaining a CTA head and neck prior to heading to the operating room. What are you looking for in the CTA that you're not able to assess in the carotid duplex?
The CTA serves as, first of all, a confirmatory study to the carotid artery duplex. The carotid artery duplex provides us the opportunity to, in a non-invasive fashion, be able to screen the patient for carotid artery stenosis. But once that's determined, sometimes additional information is needed to be able to help determine what's the best operative plan for that particular patient and their anatomy. And what the CTA does of a head and neck, it allows you to be able to evaluate the carotid anatomy from the aortic arch all the way up into the intracranial vessels. And that allows you to be able to see the origin of the carotid arteries. Is there perhaps tandem or origin lesions at the proximal common carotid arteries as they emerge either from the aortic arch or the innominate artery? And as they pass distally in the carotid bifurcation, is the carotid plaque heterogeneous? Is it calcified? Is it circumferential? And to what extent is there a channel within the area of stenosis? And then as you pass further distal to the distal internal carotid arteries, and as you go into the Petros canal and intracranial segment, the CTA provides you additional information in terms of tandem lesions or other obstructions that may be hemodynamically significant beyond the typical carotid bifurcation stenosis. Furthermore, intracranially, the CTA provides you the opportunity to be able to assess the patency and completeness of the circle willis, and to what extent there's communication between the anterior and posterior cerebral arteries of the circle willis between the left and the right hemispheres. This is important because if you are considering potentially an occlusive strategy that clamps the carotid artery, it may be of interest in these types of situations to be able to evaluate how much collateral flow will be available to the ipsilateral hemisphere during the clamping of the carotid artery. Additionally, if there's concern that the carotid bifurcation is distal or high, it may be beneficial to be able to visualize this on the CTA to plan out distal exposure for the carotid bifurcation. And this may be able to allow you to evaluate where relative to the carotid bifurcation is the digastric muscle, the mandibular segment, as well as the associated jugular vein and other anatomies in that area. And lastly, I'll mention that for transcarotid artery stenting, or TCAR, there are specific anatomical criteria that are needed to be able to determine whether or not a patient is a candidate for this type of intervention. And the only way to be able to glean these indications is using a CTA, which allows you to be able to assess the length of the common carotid artery proximal to the carotid bifurcation lesion.
Before we discuss the surgical methods in more detail, let's discuss a few rare emergent indications for a carotid artery revascularization. Now, these are patients presenting with crescendo TIAs and strokes in evolution. Crescendo TIAs are multiple repetitive TIAs within a 24-hour period, often presenting with increasing frequency and severity. Strokes in evolution are fluctuating or worsening deficits over hours to days without any definitive return to baseline. When patients present with these types of symptoms, it's considered a surgical emergency, and the thought process is it's important to proceed with the carotid artery revascularization to prevent further neurological deficits from propagating in these patients. Let's go ahead and discuss the three general methods of carotid artery revascularization. These are the classic carotid endarterectomy, the TCAR, the transcarotid arterial revascularization that you mentioned, and most uncommonly, the transfemoral carotid artery stenting. Could you briefly discuss these three methods and roughly when you would choose one?
The carotid endarterectomy approach is considered the gold standard or classic approach to repair carotid artery stenosis. And certainly this is something that has been used for the past 60 years with significant success in terms of patient outcomes, durability of repair, and the ability to have patients not have recurrent disease at the site of repair. In recent years, we've had additional paradigms emerge and with nearly equivalent outcomes, and notably the transcarotid artery revascularization approach, or TCAR, which entails a cut-down approach on the proximal common carotid artery and the supraclavicular region in between the two heads of the sternocleidomastoid. A flow reversal apparatus is utilized that reverses the blood flow out of the common carotid artery and infused back into the patient via percutaneous access in the femoral vein. Through a sheath access through the carotid artery, the common carotid artery, a stent is then deployed across the area of stenosis. And there's several studies that have been conducted to evaluate the efficacy and durability of these types of repairs, most notably the Roadster trial studied the efficacy of the in-route FDA-approved flow reversal system along with its companion protege stent in the carotid artery, and found that there was a perioperative stroke rate that was limited to only 1.4%, which is overall similar to outcomes that have been historically documented for the gold standard carotid endarterectomy. There's also another approach, which is transfemoral carotid artery stenting. This involves percutaneous cannulation of the common femoral artery, and then passage of endovascular catheters and wires to the carotid artery and selecting the appropriate common carotid artery, performing a carotid angiogram, identifying the area of stenosis, and passing through that area of stenosis to deploy a distal embolic protection device prior to then stenting and angioplasty of the area of stenosis within the carotid artery. There has been trials that have evaluated the efficacy and durability of transfemoral carotid artery stenting relative to the gold standard of carotid endarterectomy. Most notably, the CREST trial randomized patients to transfemoral carotid artery stenting versus carotid endarterectomy and evaluated patient outcomes. The outcomes were composite stroke, myocardial infarction, or death during the peri-procedure period of up to 4 years. And what the study found was that both carotid artery stenting from a transfemoral approach and the gold standard carotid endarterectomy had approximately 7.2% composite outcomes between patients of both groups. However, interestingly, when you break down the composite endpoint to individual stroke rates, myocardial infarction rates, there was some notable differences. For example, in a peri-procedural stroke category, patients that received the carotid artery stenting had a rate of 4.1% compared to 2.3% in the carotid endarterectomy. And when we look at myocardial infarction, we see that there is a rate of 1.1% in the carotid artery stenting group relative to 2.3% in the carotid endarterectomy group. Notably, death rates were almost equivalent at 0.7% for carotid artery stenting and 0.3% for carotid endarterectomy. One thing also to note from this trial is that the older the patient, the higher the risk of stroke. For example, in patients that were over 70 years old, the composite endpoint of stroke, myocardial infarction, and death was 12% in patients that received transfemoral carotid artery stenting relative to 5.9% in a carotid endarterectomy. So the take-home message here is that transfemoral carotid artery stenting can be performed in patients with lower, resulting in lower myocardial infarction rates. However, there is still a higher peri-procedural stroke rate, and that this rate of stroke is particularly elevated in patients that are greater than 70 years old.
Let's run more formally through how to perform a carotid endarterectomy, how you generally approach this case, and the relevant surgical anatomy.
Now, this is one of my favorite operations, and the way that this is typically done is that the patient is positioned in a way with their ipsilateral neck in extension. There's usually a shoulder roll placed underneath the shoulder to allow for further extension of the neck, and the head is turned to the contralateral side as much as possible to allow the ipsilateral neck to be opened up as much as possible for the exposure. A longitudinal incision is typically made over the anterior border of the sternocleidomastoid, and it's centered over the carotid bifurcation. The subcutaneous tissue is divided along with the underlying platysma muscle, and the deep fascial layers are then entered into the carotid sheath. Once in the carotid sheath, the first structure that becomes visualized is usually the internal jugular vein, which is then retracted laterally to be able to visualize the underlying carotid artery. And during this maneuver, there's care taken to obviously identify the vagus nerve and avoid any compression or injury to it. There's a major branch that is typically visualized along the carotid bifurcation, which is the facial vein, which emerges from the internal jugular vein. The facial vein helps serve as an anatomical landmark for where the carotid bifurcation typically resides. The facial vein is ligated, transected, and that allows for further retraction of the jugular vein laterally to be able to visualize the underlying carotid bifurcation. At this point, the patient is heparinized, usually to achieve an ACT of greater than 250. And at that point, the exposure is taken more proximally to identify the common carotid artery. If needed, the omohyoid muscle is transected to visualize as much of the common carotid artery as possible. It's then encircled or controlled in some fashion to allow for proximal control. Once that's achieved, then distal exposure of the ICA and ECA then is performed. Exposure of the ICA in particular, one has to be mindful of the overlying structures, which include the hypoglossal nerve, which, if visualized, needs to be protected. And then similarly, the external carotid artery is exposed, and usually in the context of exposure of the external carotid artery, the superior thyroid artery, which is the first branch off of that vessel, is also visualized. Typically, I control all these structures with vessel loops, but they can be controlled in multiple ways to allow for distal control. At this point, we then proceed with a decision as to whether or not to shunt the patient. If there's going to be a shunting procedure, I typically use what's called the Argyle shunt, but there are numerous different types of shunts that allow for antegrade flow within the carotid artery. While I'm preparing the patient for clamping, I usually get that shunt prepared, flushed, made sure to be devoid from any air bubbles or things of that nature. Other maneuvers for cerebral monitoring, if shunting is not going to be used, is a stump pressure, which entails basically clamping the common carotid artery and then measuring the pressure within the internal carotid artery using a microneedle attached to a arterial line. Other methods include cerebral oximetry, somatosensory evoked potentials, and transcranial Doppler. You'd want to get these maneuvers set up at this point before clamping the carotid artery. Once the carotid artery is clamped distally and then proximally, a longitudinal arteriotomy is then made within the carotid artery, and using a Freer elevator or a similar tool, an endarterectomy plane is developed within the vessel, and the plaque is removed from the vessel in block or in pieces. Care is also taken to develop a good endarterectomy plane along the distal ICA and ECA. And the idea here is to avoid distal intimal flaps in the endarterectomized segment of the ICA. If there happens to be a flap in that area that is noticeable, these need to either be trimmed completely or tacked down with tacking sutures, usually with a 7/0 Prolene suture. At this point, the endarterectomy site is flushed with heparinized saline. All debris is removed. Little fragments of intima are removed under loop magnification, and then the carotid artery is repaired with a bovine pericardial patch or an equivalent patch, such as a vein or a Dacron patch. Prior to completion of the patch repair, we then allow for appropriate retrograde flushing from the ICA, the ECA, as well as antegrade flushing from the CCA. The patch repair is then completed. Then an unclamping sequence is performed, and that's performed with the ICA clamped and the ECA clamped. The CCA is unclamped, and after a few heart cycles, then the ECA is unclamped, and then a few seconds after that, the ICA is unclamped. And at that point, the repair is completed. Hemostasis could be inspected, and the patient's heparinization can be reversed with protamine.
We all know some of the most important care happens after the operating room, and there's a few important postoperative complications that can occur after carotid endarterectomy. So let's talk about what you would do if your patient awoke in the OR with hemiplegia.
If there's concern postoperatively that the patient had a stroke in the OR and you're still in the operating room, one of the first things that should be done is to evaluate whether or not there's a thrombosis of the endarterectomy site. With such a rapid change in the neurological status, one thing that needs to be ruled out immediately is whether or not there's a technical abnormality to the repair site. And so by doing an ultrasound at the bedside, one can help delineate whether there's intraluminal content within the carotid artery, either at the repair site or distal to it. If the neck incision is still open, or the patient is still on the operating room table, one could also do a carotid angiogram to assess, again, the patency of the repair site. There are some endovascular repair maneuvers that could be employed to be able to remove thrombus if that's the culprit. If there is a technical issue, such as an intimal fab that wasn't recognized, that would require usually a reoperation with the reopening of the neck incision and reexploration of the carotid artery, along with some rescue maneuvers to determine whether or not there's thrombus that could be removed from the distal ICA or intracranial circulation. Let's say the patient is not in the operating room and this sort of event happens in a recovery bay or in the recovery room. A prompt CT scan with contrast could be of significant utility to be able to determine what is going on in terms of the carotid repair and whether or not there's thrombus or some sort of technical defect that needs to be repaired emergently via re-exploration.
A classic condition we watch out for on the wards during the postoperative care of these patients is the cerebral hyperperfusion syndrome. This often presents with severe headache ipsilateral to the site of the repair. In severe cases, it can evolve or involve an intracranial hemorrhage, which can be life-threatening. We prevent this postoperatively with strict blood pressure control, aiming usually for a systolic blood pressure of less than 160, or remaining within 20% of the pre-op blood pressure. Another important condition to watch out for is an expanding neck hematoma at the site of the incision, which can, in severe cases, result in issues with the airway, and should also involve a prompt return to the operating room for a re-exploration of the incision. Dr. Zayed, what is the most common cause of death in the postoperative period for a carotid endarterectomy patient?
The most common cause of death in the postoperative period is myocardial infarction. As mentioned in the CREST trial, this is not a negligible risk, particularly for carotid endarterectomy. So one should be mindful of this in terms of altered hemodynamics. Certainly if there's any ST changes on the cardiac waveform, this could be ruled out by assessing the patient's symptoms. Certainly if they're having classical chest pain. Additionally, an EKG or serologies, including a troponin, could be obtained to be able to help rule this in or out. If there is a concern for myocardial infarction, then certainly prompt management of this with hemodynamic support and a cardiological evaluation would be absolutely necessary.
Thank you, Dr. Zayed, so much for being with us today. We got through a ton of great information about cerebrovascular disease. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review can be found in the WashU Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.